The Harvest Technologies Bone Marrow Aspiration Concentrate system has been designed to automate the steps for the concentration of stem cells from autologous bone marrow aspirate. Bone marrow aspirate concentrated stem cells prepared by centrifugation increases the concentration of important nucleated cells while reducing the volume of aspirate for added clinical utility. The following video will provide the viewer with instructions and protocol to utilize the SmartPrep 2 centrifuge system and the associated sterile disposable bone marrow aspirate concentration kit. A shorthand name for this kit is BMAC, and this term will be used throughout this video. Precautions. The BMAC system is intended for use only by a licensed physician familiar with the indications and contraindications of performing a bone marrow aspiration. The BMAC system requires the physician's judgment to consider the patient's risk factors such as anticoagulant therapy or clotting disorders prior to performing an aspiration. Proper surgical techniques are the responsibility of the medical professional. The following guidelines are furnished only as recommended techniques. The physician must evaluate the appropriateness of the techniques based on his or her own medical training and expertise and consider patient-specific anatomical variations, including vascular and neural elements. Caution. The BMAC system is for single patient use only, should never be re-sterilized, is considered biohazardous after use, and should be handled and disposed of in accordance with applicable laws and regulations pertaining to sharps disposal. The instructions shown in this video will help the user become more familiar with using the Harvest BMAC kit for the following. Number 1. The preparation of the sterile disposable components used within the OR sterile field. Number 2. The aspiration of a sufficient volume of bone marrow aspirate and the recommended technique to increase assurance that a viable bone marrow aspirate is harvested. Number 3. The preparations of the sterile components used for the centrifugation and processing of the bone marrow aspirate into a bone marrow concentrate, BMAC. Number 4. The resuspension and recovery of BMAC with guidance for adjusting to the BMAC volume requirements. First, let's identify the components in the BMAC kit. The BMAC kit contains the following components. Bone marrow aspiration needles. There are 2 per kit along with 2 additional stylettes. 20 milliliter bone marrow aspiration syringes and syringe caps. There are 6 per kit. A blood bag and spike for the pooling of the bone marrow as it is harvested. A 60 milliliter syringe and 18 gauge needle used to withdraw the pooled marrow from the blood bag and to transfer the marrow outside the sterile field for processing. 10 milliliter transfer syringes used to receive the processed BMAC back into the sterile field. A beaker or basin, not supplied in the kit, needed to contain the heparin anticoagulant solution used in the collection procedure. Next, let's take a closer look at the aspiration needle. Each needle assembly consists of an 11 gauge, 10 centimeter long trocar needle and stylet attached to a handle. A closer look at the needle tip shows the stylet extending beyond the distal hole of the needle trocar and moving proximally 2 centimeters shows the 3 side holes of the needle trocar. This view shows the opposite side of the distal tip of the needle trocar, which shows 2 additional side holes for a total of 5 side holes and 1 distal hole. The multitude of aspiration holes improves the flow of marrow and reduces the risk of damaging the aspirated stem cells. A further close-up with the stylet removed clearly shows the distal and side holes in the trocar needle. In the next few frames, we'll be looking closer at the kit components as we prepare these components for use in the bone marrow harvesting procedure. In this view, the trocar needle and spare stylet are shown with their protective covers in place, along with the blood bag and bag spike used for pooling harvested marrow. This view shows the bag spike has been inserted into one of the bag ports. This next view shows the 20 milliliter syringes, followed by the transfer syringes. Now that all the sterile disposable components have been assembled, the next step is to rinse or coat all marrow contacting components and surfaces with heparinized saline. The recommended concentration of heparin used for harvesting bone marrow is 1,000 heparin units per milliliter of saline. Heparin is not provided in the kit and should be acquired from your pharmacy. It's important that this heparin concentration be used. This heparin concentration has been shown to be an effective anticoagulant for this procedure. The minimum recommended volume of heparin solution on the field is 50 to 100 milliliters, which should be placed into a sterile beaker or basin on the field. The first steps in the preparation for harvesting is to rinse all the syringes with the heparinized saline. This is accomplished by taking each syringe and aspirating a volume of heparin solution and withdrawing the syringe plunger to its maximum position. Then expel or return the heparin solution back into the beaker. These steps will ensure that all marrow contacting surfaces of the syringes have been rinsed and coated with heparin. This is an important step that will reduce the risk of clotting of the harvested marrow. Following the heparin rinsing of the syringes, the aspiration needles need to be rinsed or coated with the heparin solution. There are several methods to assure that the marrow contacting surfaces of needles and stylets are thoroughly coated with the heparin solution. This method shows the removal of the trocar needle cover, followed by withdrawing the stylet. Heparin solution is drawn into a 5 milliliter syringe and is connected to the female lure on the trocar needle handle. Heparin solution is flushed through the lumen of the needle, followed by placing the trocar needle and stylet into the beaker of heparin solution and making sure the entire marrow contacting surface of the needle and stylet are coated with heparin solution. This is another very important preparation step which should inhibit or reduce the likelihood of clotting during the marrow aspiration. If a large basin is available, the aspiration needles and stylets may be bathed in the solution of heparin, as shown in this image, which assures complete heparin coating of the external marrow contacting surfaces. Remember, heparin solution will still need to be flushed through the lumen of the needles. Another alternative method to rinse the trocar needle and stylet is to leave the trocar needle and stylet cover in place. After drawing up the heparin solution into the 5 milliliter syringe, remove the stylet and while holding the trocar needle so that the distal end is pointing up, inject heparin solution into the distal end of the trocar needle cover so that the heparin solution fills the trocar needle cover. It may also help to loosen the trocar needle cover slightly to make filling and draining the cover with the heparin solution easier. Also, attach the heparin-filled syringe to the female lure of the trocar needle and flush heparin solution through the lumen of the needle. Repeat this procedure for the stylet as well. This method makes rinsing the outer lumen and stylet easier and assures complete coating of the marrow contacting surfaces of the trocar needle and stylet. After heparin rinsing all the syringes and needles, the last step in preparing the sterile components is to place 4 milliliters of the heparin solution into the blood bag for every 60 milliliters of marrow harvested. This is accomplished by removing the injection lure and connecting the heparin solution-filled 5 milliliter syringe to the injection lure of the blood bag, and then injecting 4 milliliters of the heparin solution. After removing the syringe and replacing the injection lure, massage and rock the blood bag to ensure heparin solution coats the entire inside surface of the blood bag. Again, thoroughly coating the inside surface of the blood bag will minimize or prevent the likelihood of any clotting of the marrow once it's placed into the blood bag. This section will help in identifying the anatomy for selecting the bone marrow aspiration site using the ilium surgical approach. The ilium may be approached posteriorly, anteriorly, or laterally, with the posterior approach being suggested to minimize aspiration site morbidity. The posterior approach requires palpation to locate the superior aspect of the posterior iliac crest. The anterior approach requires palpation to locate the anterior superior iliac crest. The lateral approach requires the patient be placed in a right or left lateral decubitus position and then palpation to locate the posterior iliac crest. First, prepare the surgical site and provide local anesthesia to the area unless general anesthesia is being utilized. Make a small oblique stab incision, a skin flap, just above the point of entry. This type of incision can easily be closed using a steri-strip or butterfly dressing following bone marrow aspiration. Remember, all marrow contact components must be rinsed with an appropriate concentration of heparin anticoagulant solution, including syringes and needle lumens and stylets, to prevent clotting. After identifying the anatomy and deciding on the needle trajectory, penetration of the ileum with the aspiration needle should be swift to avoid tissue factors coming in contact with the needle lumen and potentially resulting in activation of the clotting cascade. For an anterior or posterior approach, advance the needle by applying pressure simultaneously with back and forth rotation until a reduction in resistance is noticed, indicating entry into the soft marrow space. If there is difficulty in penetrating the ileum, simply tapping the aspiration needle handle with a mallet while holding the distal end of the needle at the point of insertion and at the appropriate angle should result in swift penetration of the ileum cortex. Penetration of the cortex will be noticed by a reduction of resistance as the needle enters the cancellous bone marrow space. For an anterior approach, introduce the needle through the prepared incision site with the initial trajectory of the needle medially in line with the pelvic wing, as gauged by palpation of the inner and outer tables. The trajectory should be aimed slightly posteriorly at the iliac tubercle to enter the medullary canal just beneath it. For a posterior approach, introduce the needle through the prepared incision site with the initial trajectory of the needle approximately 40 degrees lateral from the sagittal plane and 35 to 40 degrees inferior from the transverse plane. A general rule is to aim at the tip of the greater trochanter. For a lateral approach, hold the needle horizontally and introduce it through the prepared incision site into the center of the posterior iliac prominence with the initial trajectory 15 degrees caudal. Following penetration of the ileum with the aspiration needle, advance the needle distally into the marrow space 4 to 8 centimeters for the anterior or posterior approach, depending upon the volume of the ileum. Remove the stylet and attach a heparin-rinsed 20 milliliter syringe. Pull a small aspiration of 5 milliliters of marrow. Please note that short, quick aspirations of small volumes results in a greater recovery of nucleated cells than a long pull of greater volume, which would result in dilution of the marrow with peripheral blood. If marrow does not aspirate easily, reposition the needle slightly. If marrow still does not aspirate easily, remove the syringe from the needle, remove the needle from the incision, and exchange the needle and stylet with a freshly heparin-rinsed needle and stylet. Reinsert the new needle into the incision site and penetrate the ileum approximately 1 to 2 centimeters from the original puncture site, as we described earlier. If the first 5 milliliters of marrow is easily aspirated, then the aspiration needle should be rotated 90 degrees, followed by retreating from the marrow space 2 centimeters, and another small aspiration of 5 milliliters of marrow is repeated, so that a total of 10 milliliters of marrow is now in the syringe. The aspiration needle should again be rotated 90 degrees, followed by retreating from the marrow space 2 centimeters, and another small aspiration of 5 milliliters of marrow is repeated, so that a total of 15 milliliters of marrow is now in the syringe. Care must be exercised to assure that the needle tip and side holes remain in the marrow space. If the needle tip and/or side holes exit the marrow space, the needle must be exchanged with a freshly heparin-rinsed needle and stylet in order to prevent the likelihood of clotting of the harvested marrow. Remove the filled syringe containing 15 milliliters of marrow and immediately place it into the blood bag containing the heparin solution. Agitate or rock the bag so that the marrow is thoroughly anticoagulated. It's recommended to maintain the blood bag in motion as each volume of aspirate is added to the blood bag. Reinsert the stylet and advance the needle at a new trajectory along the same plane as the original insertion. The previous steps should be repeated, assuring that the needle tip and side holes remain in the marrow space. If the needle tip and/or side holes exit the marrow space, the needle must be exchanged with a freshly heparin-rinsed needle and stylet, followed by re-entry into the marrow space as described previously. Reinsertion of a freshly heparin-rinsed stylet addresses two important aspiration issues. First, the stylet will prevent the possibility of the needle from bending or kinking, and second, advancing the needle with a distal hole and stylet in place will prevent coring of the marrow and possible blockage of the distal and/or side holes of the aspiration needle. This last issue could also result in the activation of the clotting cascade and therefore can be prevented by following this recommendation. The previous steps should be repeated so that an additional 3 small aliquots of marrow, 15 milliliters, are collected for a total of 30 milliliters in the blood bag from a single puncture site. Again, the previous steps should be repeated with a freshly heparin-rinsed needle and stylet and a new penetration into the ileum made approximately 2 centimeters from the original puncture site, or the opposite ileum can be used, so that another 30 milliliters of marrow is collected in 5 milliliter aliquots for a total of 60 milliliters of marrow being collected and placed into the blood bag. Here are a couple of good general rules to follow that should ensure a high nucleated cell yield. General rule number 1, always use freshly heparin-rinsed collection needles and syringes. General rule number 2 for marrow aspiration is to draw 5 milliliters per syringe pull, a total of 15 milliliters per syringe, and 30 milliliters per puncture site. A good way to remember this is to think 5, 15, 30. 2 puncture sites should easily yield 60 milliliters of bone marrow aspirate. General rule number 3, maintain the blood bag containing marrow in motion. Additional volumes of marrow can be harvested as needed following these guidelines and recommendations. Once all the marrow has been harvested, the blood bag should be inspected for signs of any clotting or bone spicules. Signs of excessive clotting may result in a poor recovery of nucleated cells. If seen, additional clot-free marrow should be harvested by closely following these collection guidelines. Following inspection of the blood bag, transfer its contents to the 60 milliliter syringe. This syringe will be used with the BMAC processing kit. Following the manufacturer's processing instructions, place the contents of the 60 milliliter syringe into the processing disposable, PD, by injection through the red port on the PD. The processing technician should inject 3 milliliters ACDA anticoagulant into the white port of the PD. The ACD is important to prevent clumping of the harvested platelets. The filled PD or PDs are placed into the SmartPrep 2 centrifuge for processing the bone marrow aspirate into bone marrow concentrate. Typical concentrations result in a 4 to 6 times baseline nucleated cell count and a volume reduction of marrow from 60 milliliters to about 10 milliliters. You can see in this image that packed red blood cells remained in the blood chamber. That's the one on the right side of the image. And the buffy coat containing 70% of the nucleated cells has been transferred over into the stem cell chamber. The next steps involve the removal of the cell-free plasma, followed by the resuspension of the nucleated and platelet cells in a 10 milliliter volume of plasma. Resuspension volumes can be adjusted to accommodate the clinical use requirements. These next images and video show a bone marrow aspiration using the superior posterior iliac spine approach in an actual clinical setting. Identifying the anatomy and marking out the anatomical landmarks and aspiration sites is a good start to a successful aspiration. The SmartPrep 2 centrifuge system can process 60 or 120 milliliters bone marrow aspirate within a 15-minute automatic cycle. The end result is a 10 or 20 milliliter BMAC product. Compared to an iliac bone harvest, marrow aspiration is faster and reduces the morbidity associated with iliac bone harvest. Listen to what the surgeon has to say.
Now, how long did it take you to do the bone marrow harvest, the bone harvest?
The bone harvest, about an hour and 15 minutes.
And how long did it take you to do the marrow harvest?
Marrow took 10 plus 5 minutes of getting it into the machine. 15 minutes total, and probably because we were slow.
The Harvest SmartPrep 2 system is a multi-platform automated centrifuge that can prepare bone marrow aspirate concentrate from bone marrow aspirate and or platelet-rich plasma concentrate from peripheral blood. For more information about the SmartPrep 2 system, please contact your local representative or you can contact Harvest Technologies Corporation at this address.